Okay, so today we're going to explore the shoulder, and I'm delighted to be here today with Jeremy Lewis. Hello, Jeremy.
Hi, Rachel.
Thank you for joining us. So I'd like to chat to you about the shoulder today. But before we get into the nitty-gritty of shoulder things, would you be able to tell us just a little bit about yourself so that for those that are listening, those that perhaps aren't aware of you, know a little bit more about you?
Okay. Hopefully my mum's listening out there, so she'll get to maybe get to contribute. So I was born in New Zealand. When I was 12, 13, we moved to Melbourne in Australia and finished high school there, finished my physio training there, did my MINIPS there, did a year postgraduate sports physiotherapy in Perth. We moved to the UK about 15 years ago. We came for a year to explore the UK and Europe and fell in love with living in this part of the world and have been here ever since. And I've finished a PhD and I have a sonography degree and an injection diploma degree and a biomechanics degree, and I've just finished independent prescribing. But more important than all of that, I've got 3 absolutely delightful daughters.
Oh, wonderful. That's wonderful.
Proud father.
Good.
Of course, a lovely wife. Of course, a lovely wife.
Oh, yes. Well done for remembering that. How did you become involved in... how did you become an expert in the shoulder region?
I don't know if I'm an expert. I enjoy learning and treating people with shoulder problems and doing some research in shoulder problems and supporting other people doing their research with shoulder conditions. I guess about 15 or so years ago, before we came to the UK, I was thinking I'd like to specialise in an area, and the 2 areas I was most interested in were foot and ankle and the shoulder. And I had an opportunity to work with some people doing some shoulder research, and I guess it was sort of an active passive decision to become more involved in the shoulder, which I'm very pleased that I did.
So you've been... was your PhD on the shoulder?
Yeah, it was. The thing that I was really interested in at that stage is that a lot of my training in Australia, both in the undergraduate and in the Maitland MINIPS course and also the sports course, was focusing on posture. And I know a lot of physios spend a lot of time observing posture and assessing posture and making assumptions about the patient's condition based on posture and observation and muscle imbalance and muscle length tests. And I started to realise that a lot of the ideas, I guess they stemmed initially from ancient Greece, from the time of the first Olympic Games. People were talking about the body and posture and muscles, and then there was a renaissance in the 1940s when the American Academy of Orthopaedic Surgeons started providing some sort of guidelines on what perfect posture should be. And then, but I think what happened was people provided hypotheses and ideas, and I think this happens a lot in musculoskeletal medicine. An idea gets proposed, an idea gets forwarded, and then it becomes almost written in stone. And even though people have been talking about posture for 60 or so years, even longer now, in a more formal way, there wasn't actually much to justify it. There wasn't much research validating. And so I thought my contribution could be to maybe look at some of the issues around posture and validate some of the theories. But I guess, as happens a lot in research, I think it proved the opposite. And I think more ongoing research is also challenging some of the models that we use in clinical practice. And so I was looking at posture and specifically how it influences the shoulder.
Okay. And so what were the outcomes?
You have to keep on refocusing me on the question that we discussed.
No, this is just a conversation. So, and what was the outcomes of your research then that you, in the way that you say it proved the opposite or sort of wasn't what you were expecting? Well,
one of the things I learned, and probably one of the things I learned in first year physiotherapy school in Australia, was that, for example, the thoracic had certain implications for the position the scapula sits in and certain implications then for how the shoulder moves. And the change in kyphosis also causes a postural change in the head and neck, something called a forward head posture, which I'm sure everybody's familiar with. And so we looked at the relationship between kyphosis, scapular position, forward head posture, shoulder range of movement. That was one of the studies that we did, and found there was absolutely no correlation with those postural variables. And that was part of my PhD, but more recently, a master's student I was supervising or contributing to, Liz Radcliffe, she did a very interesting, very nice systematic review that was published in January this year in the British Journal of Sports Medicine, where she looked at all the people who've done research on scapular position and shoulder conditions, specifically rotator cuff tendinopathy / impingement, and found there was no consistency in the studies on the position of the scapula. So I think, I'm not saying for a minute posture's not involved, but I am questioning to the extent that follows the rules that have been written in physio textbooks, osteopathy textbooks, and other texts.
Okay, that's really interesting. So when you're seeing patients, what are the most common conditions that you actually see?
I guess I've tried to filter patients to the conditions I want to see, and so I think the 85% of all diagnoses in the shoulder sit around subacromial pathology. So I guess that's an umbrella term for rotator cuff tendinopathy, partial thickness tears, full thickness tears, impingement, which I don't think exists, and bursal problems. And so a big part of my practice will be that group, and the other big part of my practice will be frozen shoulders, which I'm also interested in from a clinical and a research perspective, and then complex shoulder pain problems where people have maybe had surgery or multiple interventions and are just struggling to overcome their problems. So that would be a third area of clinical interest for me.
Okay, so they're your areas of clinical interest. So are there any other shoulder conditions that are really common presentations? Not necessarily just for you, but in the shoulder.
Okay, yes. I guess instability. Instability. Oh, yeah. So that would be a subspecialty. I do see patients. I guess a lot of patients with instability, but there would be other people who would be much more expert at treating that than I am, and that would be another common presentation. And then I guess another group would be post-surgical rehabilitation and post-trauma rehabilitation.
Yeah. So I guess thinking about that, the main groups from trauma, or the main direct access people that we might see, would be the instabilities, the frozen shoulders, and the subacromial. That's what you called it, isn't it? Subacromial
syndromes or rotator cuff. I actually clinically, because I guess people like a diagnosis, but it's a lot of our research and in different groups I'm working with would suggest that it's almost impossible to make a definitive clinical diagnosis. So I tend to come up with a clinical working diagnosis a lot called rotator cuff pain syndrome.
Nice, that's nice. And you mentioned that you didn't believe that impingement existed. What do you mean by that? Or explain a little bit more about that.
Okay. Well, if we go back to 1972, I think that was the year that Deep Purple's song "Smoke On" was the #1 bestseller. You weren't even born then. And it was the year you could buy the first handheld pocket calculator. Bottom price of it was $400 American. Didn't even come with a battery. But it was I think it was the same year that first arcade game, Pong. Was it called Pong? Well, your husband will know that. It was developed. It was the year that Charles Neer said that 95% of all rotator cuff problems are caused by irritation by the acromion onto the underlying bursa and supraspinatus tendon. And on the his first paper is a really interesting paper for people to get a hold of, and it's not a research paper of any description. It's really a clinical opinion. This is what I think I've been observing paper. This is my hypothesis paper. But it really did spawn an industry, so much so that in the 10 years up to 2010 in the United Kingdom, there's been a 750% increase in the number of subacromial decompressions performed into the period. So I think 2006 in New York State, a 250% increase. I just came back last night from a conference in Copenhagen, and people were presenting data from Sweden, where I think there's been I've forgotten the number, but there's been an increase. I've got it written down somewhere. There's been an increase, a massive increase in the number of procedures performed in Sweden of the same procedure. Huge expense to health services, huge expense to healthcare providers, and at considerable cost to the individual as well. Now, of course, if something is beneficial, then we should find money for that procedure. But the research evidence clearly shows that physios are not offering second best treatment. No one wants to go to a doctor and be told they're getting second or third best treatment, and no one wants to be giving it. And exercise therapy has been proven to be as effective for surgery, if not better, for subacromial impingement, partial thickness cuff tears, and also full thickness atraumatic tears. And the original hypothesis was that the acromion was causing the irritation, but some of the research we've done and some of the reviews we've done would suggest that the acromial hypothesis, the acromial theory, is really not really well supported at all. And what probably is happening in most cases is a muscle weakness is allowing the humeral head to translate superiorly, lift up towards the acromion. So instead of removing the acromion, it makes more sense to treat the primary problem, which is a muscle imbalance. And in addition to that, a PhD student I was supervising last year, a brilliant physio, Karen McCreesh from University of Limerick in Ireland, who did a wonderful PhD thesis looking at what happens when you overload rotator cuff tissue. And similar to other tendons, it seems to swell quite quickly. And so the ideas that I've been working with for the last few years is not the acromion is pushing down, causing the irritation. It's either a muscle imbalance causing the humeral head to slide up, or an overloaded swollen tendon putting pressure under the acromion. And in those situations, you want to restore homeostasis to the tissue that's the problem. And so very, very few people actually need surgery. Most people, which is borne out by the research evidence, just need a good exercise program to treat the condition.
Yeah, and in some ways that comes back to what you were talking about earlier, in that it's not the posture of the scapula, but it's the posture or position of the humerus that's causing the problem. Potentially.
I developed, published in 2009, something called the shoulder symptom modification procedure. And if I can put in a little plug for my website, people can download it from the website. It's www.londonshoulderclinic.com. I had an absolutely amazingly brilliant web designer help me design it. I totally recommend that particular individual. You should put that banner coming across the screen now. Very jealous of his skills. And people can download.
For anyone that's listening, that is our Tony, the Physiopedia technical chappie that works behind the scenes. So just to explain that comment.
Okay, no, he's highly recommended. I'm not getting paid for this. So people can download it from the website. And what I've tried to do, looking at the research on posture, is come up with a system to try and assess posture, not from observation and not from muscle imbalance tests, but how posture influences the particular individual symptoms. And part of that is looking at the scapula. So sometimes the scapula is involved, but not, I don't believe it follows the definitions that have been published in the literature.
Okay, yeah. Just remind me what that was called again?
The shoulder symptom modification procedure.
Shoulder symptom modification procedure. Is this, so on your website it mentions the unique system of shoulder assessment and treatment that you've developed. Is that?
That's it.
Yes, it is. Is there any more that you'd like to explain about that? How it can be used and what it is? A little bit more about what it is.
Okay, so I guess it's how I start most of my assessments. It doesn't take very long. It probably takes about 5 to 10 minutes of clinical time, and it has 4 separate components, but they are interrelated. The first part of it, first of all, it's very patient-focused. The patient identifies what's causing them a problem, what's causing them grief during the day. It could be a posture, it could be a movement, it could be an activity, a tennis, hammering nails into walls, a push-up in the gym, or simply making a cup of coffee in the morning. So the patient identifies things that are causing them a problem. It could be a problem of pain, it could be a feeling of instability, it could be pins and needles, whatever the problem is. And then I apply the algorithm to that, and the first section looks at the influence of spinal posture on that, looking at how spinal posture increases, decreases, or doesn't change the symptoms. Then I move more laterally to look at the relationship between the scapula and symptoms, looking at 3 planes of movement and combinations of movements. And then move a little bit more laterally again to look at the relationship between the humeral head and the glenoid fossa on symptoms, and then put all that together. And then the final part is looking at what I call neuromodulation procedures, and I guess some people might call those joint mobilization procedures or trigger point procedures or acupressure procedures or taping. Anything that involves some form of touch, I tend to lump together as neuromodulation. And if the earlier mechanical procedures don't change the symptoms, I'll then look at the role of neuromodulation on symptoms. And of course, it doesn't. Sometimes it works a treat. Sometimes it doesn't change the patient's symptoms at all. It wouldn't work in a patient with a frozen shoulder. And sometimes it partially alleviates symptoms. And in most cases, it partially contributes to reduction in symptoms. And then what's often left, what I find in my clinical practice, is something like a rotator cuff or a biceps tendinopathy, and that needs a bespoke treatment in addition to whatever the shoulder symptom modification procedure provides for the patient.
And that shoulder symptom modification, yeah, so you've said, so it could be an exercise or a manual therapy technique or taping or trigger points, things like that.
Well, that would be the least common component of it. And it's a very simple process, because whatever works as an assessment becomes the treatment. Yeah. So it doesn't rely on someone to come up with a structural diagnosis, because again, research I've been involved in, a couple of book chapters and research I've been involved in this year with others, would suggest it's almost impossible to come up with a definitive structural diagnosis. And the findings from ultrasound and MRI are important, but they often don't tell us where the symptoms are coming from. So clinicians, whether they're physios, osteopaths, chiropractors, and orthopedic surgeons, currently, with current technology and current knowledge, are at a real struggle to come up with a definitive structural diagnosis. And for sure today, in every country in the world, there'll be people having operations on tissues that are not causing their symptoms, but they're having those operations on the basis of clinical tests that can't really tell us where the symptoms are coming from, and on imaging that's identifying structural pathology but not telling us, there's no little blue light flashing saying that this particular structural pathology is causing the symptoms. And so the SSMP, the shoulder symptom modification procedure, is a stopgap measure that I think has identified problems in our clinical assessment, and I'm waiting for the ultrasound machine or the new MRI machine that flashes a blue light or rings a bell saying this actual identifiable structural problem is the cause of this patient's symptoms.
We're certainly
it's a simple process. Once you've applied it, if nothing works, you move on. If something works, whatever worked as an assessment is the treatment.
Yeah, sounds really interesting. We will certainly download that and encourage others to have a look at that as well with this alongside once they've listened to this. So when you've done the SSMP,
that's it. You're almost an expert, Rachel.
We're all going to be an expert. What are the most common treatments that you actually sort of end up using? Are there any that are more common than others? Are there any that are more useful to have in our toolbox? Things like that.
Every patient is very individual. As I said, there's three main postural assessments: kyphosis, the thoracic spine, scapular position, humeral head position. Each of those has a number of tests, and each patient will be individualized according to the response to those tests. So it would commonly be a combination of some spinal posture, some scapular posture, some humeral head posture, some neuromodulation, but it would vary the percentage within each of those categories for each patient.
Okay. So nothing in particular stands out as that you see more often or anything. It just really varies, and is it totally individual for the patient?
If I had to be putting a percentage on it, it would probably the order of the most common change would be scapular posture, followed by humeral head posture, followed by kyphosis, by thoracic spine posture.
Oh, interesting. Yeah. Okay. So we've talked about your SSMP model. What do you and this question isn't probably I probably know the answer to this question already, but what is the most important thing that physios need to be aware of? So when that person walks through the door with their shoulder complaint, what is the most important thing that we should be thinking about as we start our assessment with that patient or with that individual with shoulder pain?
To try and totally understand how the problem is influencing the patient in their day-to-day ongoing life, and what they want, what their aims and expectations are. Part of the conference and teaching I just came back from in Copenhagen, there was some really fabulous lectures from psychologists who were talking about language we use and how we should introduce ourselves, and how obviously and every physio on the planet knows from previous reading they've done that how important it is to allow the patient to express themselves without interruption, to allow them to explain in detail what's causing their problem, how it's manifesting, and what they want to achieve from the interaction with their clinician.
Because that gives us goals to aim for with the patient, and also gives us an understanding of what their expectations are.
Absolutely, and I think sometimes health professionals, and it's certainly been borne out by research from South Africa and other places, where we maybe assume what we think we know what the patient wants, but it may be completely different to what actually that individual wants.
Yeah, because if we're working towards something different than the patient or the individual shoulder pain is after, then it's unlikely that we're going to get that positive result that we're looking for, isn't it?
Absolutely, and it's what we all have to be much more patient focused. But I think I've had the great privilege of travelling and teaching in lots of countries over the years, and I think that physiotherapy communities generally are people who either choose to become physios, or the training within physio creates an incredibly generous, nice, humble group of people, and who are very much focused on the patient and the individual. So whether it's genetics or education, or I don't know what it is, but wherever you go, physios are lovely people.
We're all nice people. That's exactly what I was going to say. Mm-hmm. So for a physio,
can I just say here mostly?
You can, yes. Yeah. For a young physio who's wanting to, let's say they're wanting to specialise in managing shoulder conditions, what sort of skills, we've talked a lot about assessment, what sort of skills would you encourage them to try and gather so that they can be effective in managing individuals with shoulder conditions or shoulder pain?
I guess that's a really good question. And I've had lots of conversations with people who specialise in other areas, whether it's backs or knees or another shoulder, people who have an equal interest in the shoulder. And I guess it's a lot of things. I guess it's the 10,000 hours of clinical practice that you need to acquire. I guess it's also gaining confidence in all sorts of areas, gaining confidence in yourself as a human, being able to communicate with other humans. It's reading a lot, but not just reading. Before you start reading, you have to acquire certain skills. So you have to acquire the skills to read a research paper or listen to someone present at a conference and have the skills and the confidence to be able to critically appraise the quality of what you're reading. So you need to acquire clinical skills, you need to acquire research skills, as I said, in the ability to understand the quality of what you're reading so you can actually translate research that's meaningful and will inform practice. You have to understand concepts such as numbers needed to treat. You have to listen to people humbly and listen to their ideas, and you need to attend courses. You need to listen to the wealth that will be available, the wealth of information on your website, which is an amazing resource, and others as well. So you just have to acquire lots of information, lots of experience, and talk to people, find a mentor, do some research.
Yeah. What about practical skills?
Again, that would possibly be informed by practically, I guess, either watching things on educational websites, attending courses, having your practical skills observed and some feedback given to you. But in the main, the research evidence in the main at the moment suggests that exercise is probably the strongest medicine we have in a lot of musculoskeletal conditions, and it's probably, if some of the pharmacological companies could bottle medicine as a pill, they would be making a lot more money than heart disease and insulin and Viagra and all those different medicines combined. So it's becoming an expert at delivering exercise, understanding the physiology of exercise, understanding how it changes in a younger person as a person progresses through middle age to become geriatric population. So I actually think good clinical skills at the moment require wonderful communication skills, an ability to listen and empathize, but also to have good cognitive skills as well, to be able to explain to a patient diagnosis as best you can and prognosis. But in terms of practical skills, which I think I'm meandering a bit away from the question, sorry, but I think it's to become expert in exercise prescription. I think a lot of the neuromodulatory techniques, a lot of people spend a lot of time acquiring mobilization skills and trigger point skills and acupressure skills, etc. And this statement isn't meant to offend anybody, but I think a lot of those things are almost identical physiologically. I think that differs between them is the philosophy of why you're touching. So I think those skills are good for neuromodulation, but I think the bread and butter of what we're doing, borne out by research, is exercise.
Excellent. I think that's some great advice there. So I want to just ask you now, so after we've assessed our patient with the SSMP and treated them...
You don't have to, it's what I do. Yeah. There are other ways.
Yeah, fair enough. So after we've assessed our patient and done some treatment with them, given them their exercise program, you are obviously qualified in sonography and injection therapy and independent prescribing. So when do you use those skills, and when can people when should people consider referring to someone like yourself who has those skills?
Okay. Let me just listen to say I've just finished the course on independent prescribing. It's probably, of all the things I've done, it's probably the hardest. I didn't have any grey hairs before the course, and I've aged 20 years since it. I know that I've preliminarily passed, and I'm waiting just for it to be ratified. Okay. So then I have to change my annotation with the my professional body. Yep. So I haven't actually independently prescribed anything yet. Although I have got friends in the street who are keen for Botox, but I don't think I'll ever prescribe that. So I currently work under something called a PGD, which in the UK is UK physios know as a system that allows us to use medicines in certain conditions. And I've done that for many years. I trained as for many years I've been doing ultrasound guided injections for different shoulder conditions, and I have been aware of the literature for a long time that may suggest that that you might observe something with an ultrasound scan, but it might not be the cause of the symptoms. So my main reason for acquiring the sonography skills were to further enhance my ultrasound guided injection skills, but also to do research. So Karen McCreesh, who I mentioned earlier, the PhD student from University of Limerick, a lot of her research was around measuring the rotator cuff tendons with ultrasound. So the main reason was for research and to improve my injection skills. So when should someone refer to someone like me? I don't know how to answer that. I guess if someone is looking for a second opinion or an alternative viewpoint, I'm not sure I'm going to get a person better than anybody else. I just sometimes think that sometimes second pair of eyes, second conversation might find a different direction for a patient. I'm not sure that I'm not sure that anybody's going to really make a much bigger difference than anybody else clinically.
So, are there any patients or conditions or presentations that are more suited to injection therapy?
Absolutely. So published a paper earlier this year in Manual Therapy, and I think it was in January, where we tried, it was more a narrative review, but tried to synthesize the evidence for best management for frozen shoulder, which is a really horrible condition, probably one of the more painful conditions of the shoulder, and it's very protracted. The average time someone suffers is about 30 months, and there's been studies that demonstrate that even at 4 years, 7 years, 11 years, and even up to 20 years, somewhere between 40 to 60% of people will still be suffering some pain and some restriction of movement. So it's not a condition that resolves with everybody, even though the literature suggests that it does, and we tell people it does. That's not been proven to be correct. And we don't have a perfect treatment for frozen shoulder at the moment. We don't have a perfect treatment for anything in musculoskeletal conditions, but I think patients can be quite confident, and clinicians can be quite confident as well, that a combination of intra-articular injection therapy, possibly involving a steroid injection, linked intimately with physiotherapy management, can be a very successful way of, in most patients, of reducing pain. And then what we also do in our clinic besides that, so we do initially from the pain stage, we do intra-articular steroid injections followed by, coupled together with physio, and we also do a technique called a hydrodistension, which is hydro's water, so using water to distend the shoulder, again under ultrasound guidance, so sodium chloride, salty water, to inject into the shoulder to stretch it from the inside to try and restore some movement, and then again immediately start with physio. And we've had some really amazing success with that approach, and we're doing some research around it and trying to find better ways to improve the patients. It's not going to work with everybody, but I think at the moment, based on the research evidence, it's probably the best combinations of treatments.
Interesting. And what about, let me just ask you, what about injection therapy for tendon conditions?
Okay, so again, the research evidence would suggest that injection therapy by itself for rotator cuff tendinopathy isn't probably going to cure the problem. If anything, injection therapy is only going to reduce the pain in order to allow the important medicine, the exercise, to be effective. I recently, I guess the last couple of years, have tried not to inject steroid near tendons. I think there's emerging evidence that suggests steroid in tendons is not a good combination. There is clinical evidence that suggests that an analgesic, a lidocaine injection, is as effective as a steroid injection. When you look at randomized controlled trials ranging between 2 weeks to 6 months, when people are being compared between those two interventions. So if lidocaine has the same clinical effect as steroid, and steroid is detrimental on tendon tissue, I wouldn't go to a steroid injection first. If someone can't cope with the exercise progression that's been prescribed for them, and we need to try and settle their pain down to allow the exercise to work, I would tend to do an ultrasound-guided lidocaine injection into the subacromial bursa to facilitate the exercise. Then there's, of course, always the option to do steroid at a later time if that's needed, but to try and avoid steroid initially. And of course, any medicine, there's no medicine that's not without risk. So lidocaine is also with risk, but it's probably a lesser risk in as long as the patients are appropriately screened and consent and understand the benefits of the procedure, but also understand the risks of the procedure. Well, there's also a physiological reason. So we often tell our patients that we're giving steroid to control the inflammation, but again, it's embarrassing actually how little knowledge we have. And my star sign is Libran, and I don't make decisions very well. But and I sit on the fence completely with this. If someone tells me that the tissue's inflamed, I don't believe them. If someone tells me it's not inflamed, I don't believe them. It's very hard to be sure about that. But what's interesting about lidocaine and steroid is they both seem to have this ability to reduce tenocyte numbers, and tenocytes are the cells in tendon, and they produce tendon tissue, and they produce the proteoglycans that surround the tendon fibers that attract water, and they seem to increase in number in acute tendon conditions. And maybe one of the benefits of both steroid and lidocaine is to promote homeostasis back to the tendon by reducing these increased numbers. So maybe there's reasons that we don't know why these medicines are actually working, but steroids and rotator cuff, I would try and avoid it if possible.
It sounds like from the things you've been saying about frozen shoulder and about the sort of subacromial conditions, that the injections are useful to reduce pain so that the individual can get on with their exercise program. Is that correct? Yeah, good. Okay, so we've covered quite a lot there. Is there anything about the shoulder that we haven't talked about, that I haven't asked you about, that we've missed, that you feel that you'd like to tell everyone about or mention?
We're doing a lot of different researches at the moment. I've got had the big privilege of supervising or contributing to supervising Rachel Chester's PhD. She's based at the University of East Anglia, and she's about to start publishing her work, and she did an absolutely brilliant prognostic study looking at how physiotherapy, which patients will benefit from physiotherapy interventions. I've got some more research supervising another PhD student, Fiona Sanford, at the moment, who's looking at nutritional supplements to try and see if they, in combination with exercise, are beneficial for moving patients with shoulder pain on. We've just finished a very large acupuncture and shoulder pain study, which I can't reveal the data at the moment, but it's very exciting findings. And we've got some injection therapy research coming on as well. So there's lots going on. Lots of national and international collaborations, which has been actually a great honour to to meet and work with other people. And I guess what all that tells us is if there's a need for so much research is that everyone, if they could, needs to contribute to the research agenda in any way, because if we really do want to make the best, improve our patients the best possible ways that we can, we need more information to be able to do that. So if anyone has got some interest in research, get involved in a local research group or start your own study, because it will help the members of our communities that we're serving, I guess is a good take-home message.
Good. I'm really interested in the prognostic studies and the nutritional studies that you are working on. I'm very excited to read about those when they come out, so please do let us know so that we can read about those and share those.
Well, you need to speak to Rach. You need to have a conversation with Rachel Chester about the prognostic study. She's an absolutely brilliant physio and done a wonderful body of research, and I think her findings are going to be very informative to anyone who's interested in shoulder pain.
Okay, we'll do that. Good. And just one final question then. What for the future, do you think, for shoulders?
Okay. What for the shoulder? For the future?
Future. Where is our work with the shoulder going to go?
I guess what we desperately need is, for the common conditions, it's like a little bit of what I was saying before, that we've got all these conditions that we think we understand what they are, we think we know how to manage them, we really don't. A lot of what we're doing is based on what people said in the 1930s, 40s and 50s, and we've not added always a huge amount of information to that. We're very stuck in this structural model that the structure is causing the symptoms, and the research would suggest it's clearly not. We need a greater understanding, like in low back pain, of the biopsychosocial model. We sort of got a very structural model for the shoulder, but I think there is some research moving us to understanding it's probably like a lot of the other musculoskeletal conditions. There's a huge psychological component that maybe we're not addressing. We maybe need to focus away from local tissues to more central tissues, understand the role of central sensitization on shoulder pain. And again, I've got a collaboration going with Laval University in Quebec in Canada on that, and also in London as well. So we don't know much. We need to know a lot. We need to know a lot more.
Good. Okay. Well, that's great. I think it's exciting for the future. It sounds like we do well, but it sounds like there's quite a long way to go with the shoulder. So there's probably some exciting things to come out to help us help our patients or individuals with shoulder pain, which I think is quite exciting.
I guess, sorry to interrupt, but I guess a really important take-home message from this is that no one wanted to go to their doctor today to be told by their doctor they're getting the second or third best treatment for the condition the doctor's diagnosed. And physios who are listening to this, or anyone listening to this, should take away from this enormous confidence that they're not offering second or third best treatment. They're offering as good treatment, if not cheaper and faster than surgery. Our challenge isn't with another profession. Our challenge is to find what we're doing at the moment, what we're doing well at the moment, but even better. And I guess that's a really important message as well.
Yeah, I think you're right. We are doing a good job at the moment. Things can only get better.
Yes.
So, okay, well, respectful of your time, thank you very much. I don't think I have any more questions for you. I think that's been really informative. It's been really interesting to talk to you and to hear about your work and what you're doing in the future and with all your PhD students. So thank you very much. Thanks for your time.
Thank you very much for taking the time to have a conversation.
Yeah, you're welcome, and I hope we'll talk to you again in the future.
Absolutely.